First of all, again, my congratulations for these absolutely top-level lectures I heard in the meantime. But there are a lot of, I would say, truths that we have to accept. When you are talking about cavernous sinus, and if you read in my skull-based book, which is more than 40 years, in 2 pages, I make some statement. I made a such statement that is still is the same. I would not change it. That is that what I told to my pupil. Dolens has studied with me, learned from me microsurgery, and I helped him many years. That is that what I told him also as he started. We must be very honest with us and with the patient. Do you know how many people are killed because of cavernous sinus surgery around the world? The young people started to be great skull-based surgeon, and I do the cavernous sinus surgery. And I know that they gave me the report. 25 years later, Vinko has asked me, please come, I want to make another meeting. And in the second meeting, he exactly said what I said 25 years ago. I am afraid about cavernous sinus, and we must be very careful, and we are not a great surgeon if we are entering into the cavernous in every meningioma which infiltrating all the time. It is not good. We should be careful. That is I am citing now the Dolens 25 years, after than 25 years around the world. People are starting, the young people, to be better than the other. I am cavernous sinus. You have done a wonderful lecture. I like that you try to speak about all pathologies, different pathologies, and they are completely different. Every pathology is different in cavernous sinus. You cannot put all as a salad in a top and say, yes, I am doing cavernous sinus. Now, I have done all the pathologies, and in the right time, I made my statement. I said, a meningioma which infiltrates into the cavernous sinus, and the patient has a still good oculomuscular muscle. It is really not acceptable to operate this person, create ophthalmoplegia for all the life, and this patient can live another 25 years by natural history, and then this is not acceptable, This is something that young people have to know that. And there was one thing. The natural history, when it's better than the surgery, leave it to the natural history and not try to. But you gave a fantastic lecture with a variety of things. But please tell in your lecture that in infiltrating cavernous sinus, I am afraid to kill all the ocular muscle nerves and so. But there is indication. They compress the optic nerve. They compress the oculomotor nerve, which is also surrounded by the tumor. You can do it. But if you go and then say some other people who want to be better than cavernous sinus surgeon, they have started to resect in the cavernous sinus the carotid artery and make for a little bit meningioma, reconstruct the carotid artery extra intracranial. It's not acceptable, and therefore this has to be done. I need to tell that in this MASSIN Congress that we should always have the patient in the center of our objective, and now what we are doing. And therefore, please, in the next lecture we are going to give, go to this file and tell that to the young people, that they know how many risk is in this surgery when we continue and do that. I'd have done, believe me, in the 70s, I have burned my fingers with some cases, and then I took that and I have written that in my book, exactly what is the cavernous sinus surgery, and particularly in meningioma. The other things, chordomas or schwannomas, the best surgery which I have done, do you know what it is? Cavernous hemangioma. They are well capsulated. You can take from cavernous sinus without any problem. I have a series of these cases. Therefore, it's different. I'm sorry to say that, but this is probably a very sensitive area of scalp surgery. Thank you.
Let's have each moderator ask one question and we close the session.
Sure. Dr. Sina, the goal of our surgeries is to treat, the goals of our surgery is to treat the pathology, to preserve neurologic function, to preserve cosmesis, and to reduce pain. When does it become pushing it too much from a, I want to do less and less and less at the cost of where safety is? What's the balance?
So keyhole does not necessarily mean that you cannot take out the whole of the tumor. Absolutely not. Believe me. Keyhole surgery does not compromise in any way the extent of tumor resection, number one. Now, yeah, there are certain principles that you have to follow with a keyhole approach, that the placement should be absolutely accurate. It has to be under image guidance. Open the dura, drain the CSF, flow in these cisterns, and then you are on the tumor. So as far as the question of taking the tumor out incomplete is concerned, it is not the limitation of the keyhole approach. Now, what happens is sometimes you have to leave the tumor in the interest of the producing a neurological deficit if you go on to chase the tumor. That is a different story. I hope I answered your question.
I'm going to keep it real short, quick here. Sean, I was real interested with that optic nerve sheath meningioma. How did you handle the globe? Did you just take out the tumor itself?
No. The globe, the lamina papyracea is not open.
Dr. Ross.
You're asking me?
I'm sorry, I was asking Dr. Ross.
Okay.
In terms of handling the globe itself?
And the surrounding tissues. Did you just take out the tumor or leave all that behind, or take it?
Yeah, I mean, within the intraconal space, it was pretty well defined. So I basically just amputated the nerve right behind the globe, and then worked in the between the superior rectus and lateral rectus, and worked lateral to the superior ophthalmic vein to try to preserve whatever remnant third nerve function there was. And so just cut it there, chase it back to the annuluses in, open up the annuluses in, and divide it there, and then divided the rest of the tumor after doing clinodectomy along the canal, the tuberculum cella itself. So luckily, it didn't infiltrate into the globe, so we were able to save it. I think the one issue with those cases, though, is just ultimately the globe becomes atrophic, right? The vascular supply goes away. So cosmetically, it's not the best outcome, but then they can always be reconsidered for like a prosthetic down the road if that wanted to be the case too.